Hi. Okay, we'll get started. It's 12 noon. Welcome everyone to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Just a brief reminder to please leave your questions till the end. I ask that you please enter them in the chat. As well, please answer a brief survey that will be sent to you immediately after the presentation. It will let us know that you are present today. Finally, we have a special speaker today. It needs no introduction to many, but nonetheless, I will introduce our chief of our research institute, Dr. Rhian Touyz. As you know, she's the executive director and chief scientific officer of the Institute, which is the Research Institute of McGill University Health Centre. She's the Canada Research Chair in Cardiovascular Medicine and the Dr. Phil Gold Chair in Medicine here at McGill. She served for 10 years as the director of the Institute of Cardiovascular and Medical Sciences and BHF Chair of Cardiovascular Medicine, University of Glasgow, and we were very, very fortunate to recruit her here to lead our research institute in 2021. Dr. Touyz is a clinician-scientist focusing on molecular mechanisms of hypertension. She is an elected fellow of the Academy of Medical Sciences, Royal Society of Edinburgh College of Physicians, Canadian Academy of Health Sciences, and Royal Society of Canada. She has received numerous awards, including Hypertension Research Excellence Award from the American Heart Association, which is the highest honor in the field. Dr. Touyz is also editor-in-chief of Hypertension, and she's a strong advocate of equal opportunities for all in academia and research. She founded the Women in Hypertension Research Program of the International Society of Hypertension. For the trainees online and in the room, if you want sort of a barometer to aim for, she has published over 665 peer-reviewed papers and has an H-index of 152, citations of over 150,000. Okay, this is, I've seen the list, this is by far the greatest and the highest list of published papers and H-index that we have at McGill. She has an interest in translational research where her discovery science impacts care of patients with hypertension and cardiovascular disease. I could go on and on. I will just put as a last statement, she is mentor to many. She has supervised over 105 graduate and postgraduate trainees and is committed to mentoring young and mid-career researchers. This is a very abbreviated CV. It's a great pleasure to have the honor of having the chief of our, the executive director of our research institute present to us today. Dr. Touyz, the floor is yours.
Okay, so it is such a pleasure for me to be here today and to talk about an area that obviously I'm very passionate about. And from a clinical point of view, I thought it would be really important for me to share with you the latest international guidelines on the management of elevated blood pressure and hypertension. So, why do we need new hypertension guidelines? And I'll be presenting to you the 2024 guidelines of the European Society of Cardiology. Well, I want to take you back to 2009, where Avram Shabanian said, or developed the notion of the hypertension paradox, because already in 2009, it was evident that we had more uncontrolled disease despite improved therapy with respect to hypertension. However, in 2025, the prevalence of hypertension continues to increase. The number of patients effectively managed remains suboptimal. In fact, blood pressure control is worsening globally and especially in women. And I want to remind you that it's not infectious diseases or cancer or other metabolic disorders, but it is hypertension that is the major modifiable risk factor for morbidity and death globally. And if we just look at the global attributable deaths and risk factors, we can see year after year after year that high blood pressure is the number one. And the reason for this, as we know, is that high blood pressure predisposes to cardiovascular disease and, of course, is associated with chronic kidney disease, with diabetes, stroke, etc. Now, because of the importance of hypertension globally, of course, there's been huge efforts to do a better job in controlling hypertension. And indeed, in the US and in other parts of the world, the trends for improving blood pressure control were actually, there was a positive trajectory. However, over the past 10 years or so, blood pressure control amongst adults with hypertension is actually declining. And these are the national HAINS data, and the similar data are found in Europe and in other countries as well. What do things look like in Canada? Similarly, too, while the control was not too bad, what we see more recently is that control, and when we talk about control, we talk about blood pressure based on guideline normal levels. And we can see, too, over the past 10 years or so, there's been a decline in the rate of control in Canadians, both in men and especially in women. I also want to highlight to you with respect to hypertension control, these are data from about 2 million individuals. About 50% of patients know that they've got hypertension, as indicated by the light blue graphs across all age groups. Of this 50% that know that they've got hypertension, only 35% are treated. And of the 35% that are treated, about 13% are treated to target. And so you can appreciate that the number of people walking around with uncontrolled hypertension is huge. And all of these individuals are at risk of cardiovascular disease, cerebrovascular disease, stroke, even vascular dementia is now considered an importance in terms of risk factor for hypertension. Now, if you go back to your basic physiology textbooks and your clinical textbooks, you'll know that the pathophysiology of elevated blood pressure is actually very complex. We know that there are a number of physiological systems, the kidney, the heart, the brain, the central nervous system, the vasculature, all important in the pathophysiology of hypertension. But in addition, genetic factors, behavioral factors, environmental factors such as pollution, and of course, socioeconomic and psychosocial factors all contribute to elevation in blood pressure. But at the end of the day, it's the persistently elevated blood pressure and hypertension that lead to hypertension-mediated organ damage that we now define as HMOD, for those of you who may not be aware. Hypertension-mediated organ damage comprises left ventricular hypertrophy, for example, changes in the kidney, the microcirculation, the large vessels, the brain, and of course the retinopathy of hypertension. And it is these target organs that really are at the base of what causes the morbidity and mortality. And so preventing and treating hypertension is what our mission is in terms of clinicians, and especially those who are interested in hypertension. Because by preventing and treating hypertension, we could reduce the HMODs and the consequences in terms of the chronic diseases that really plague and are a huge burden to our society and, of course, personally. So in 2024, we published in the European Heart Journal the European Society of Cardiology guidelines. It took 2.5 years with meetings that took place almost every week to produce these guidelines. And this guideline actually comprised an international group of experts who contributed to these guidelines. I was happy to invite Stella as another Canadian to contribute to the guidelines, but a really fantastic group of experts. I chaired the guidelines with a colleague from Ireland, John McKeevoy. And these are the members of the committee, of the guideline committee. And as I said, after 2 years, we produced evidence-based guidelines. So for those of you who are involved in guideline preparations, you'll know that it's very important to establish the classes of recommendations. We had class 1, class 2, 2A, 2B, and class 3, with class 1 being the greatest evidence for the recommendation. And we had very specific wording to ensure that the message was very clear. So class 1 was the greatest evidence in terms of based on meta-analyses, randomized clinical trials, and other very robust and rigorous clinical studies. We also used 3 levels of evidence for our guideline recommendations, level A, B, and C. And of course, again, level A being the most robust, data derived from multiple randomized clinical trials or meta-analyses. And we use these levels of evidence, again, to ensure that our recommendations were based on the most up-to-date, the most robust, and the most rigorous clinical information. So we updated the clinical guidelines in the European Society of Cardiology from those that were published in 2018. And we came up with 57 new recommendations, again, based on the evidence, and we modified or suggested recommendations to over 100 recommendations that were made in 2018. The document, of course, was very long. It comprised all the references for all the evidence in a supplementary document. But what I'll share with you today are just some highlights, the more important aspects in terms of what is really new in terms of recommendations in managing high blood pressure and hypertension. I will just briefly mention the importance of measuring blood pressure correctly. But probably the most important change was that we actually came up with a new definition and classification in terms of how we understand high blood pressure, diagnosing hypertension, preventing and treating elevated blood pressure, managing specific patient groups, and also an emphasis on patient-centered care. So one of the most important aspects in making a diagnosis of elevated blood pressure or hypertension, of course, is to ensure that the measurement of blood pressure is correct. And so we have come up again with very clear recommendations that it's absolutely essential that when blood pressure is measured, it's important to use validated and calibrated devices and to ensure that the proper technique is used. And this is both for in the office blood pressure, and even more importantly, for home blood pressure measurements. Now, if you go on Amazon or Google, you'll see that there are many, many devices now that you can buy to measure your blood pressure at home. I can tell you that 80 to 90% of these devices have not been validated. And there is now a site where we actually validate the machines. And this validation, it's important that the machines that are used at home are validated machines. But what I do want to emphasize to you, it's not just simply a matter of putting on a cuff and pressing a button to measure the blood pressure. The technique really includes the assurance that the patient is sitting in the proper position under the right conditions. For me, one of the most important criteria, very interestingly, is that when you measure blood pressure, it's really important that the patient has good back support. I can tell you that there can be an artifact of up to 8 millimeters of mercury if your patient does not have good back support. So ensuring proper posture in the right conditions is really important. And we gave this evidence a class 1 and level B. So the question, of course, for all of these guidelines and for us as clinicians is, so what really constitutes normal blood pressure and what constitutes high blood pressure? Because at the end of the day, the normal distribution of blood pressure is really a bell-shaped curve. But we can see that if you take populations, and these populations can be anywhere in the world, the normal systolic blood pressure is about 110 millimeters of mercury for the majority of the population. So then, if the majority of the population has a blood pressure of a systolic of 110, what is the definition then of hypertension? And if we go back to the very famous words of the very famous epidemiologist Jeffrey Rose, who insists that sick individuals and sick populations can be defined, particularly with respect to hypertension, as merely the blood pressure level above which investigation and treatment do more good than harm. So with that, since the early 1960s now, there have been many studies, many clinical studies, many clinical trials in actually defining what hypertension should be categorized as. And you can see very early, actually, hypertension was diagnosed as a blood pressure greater than 160 millimeters of mercury. And that was in the 1980s. And this remained until about the 1990s when blood pressure targets started to drop. And we can see in 2005 that blood pressure greater than 140 systolic was now identified as being hypertensive. In the 2018 guidelines, there were a number of different categories for hypertension. Normal blood pressure or optimal blood pressure being less than 120 over 80, normal 120 to 129. They said high normal 130 to 139, and then they had various grades of hypertension. But this became very clumsy, in fact, for the very busy clinician, seeing patients coming in and out to start defining and categorizing patients such as this. And so it was really important for us bringing together this new guideline to ensure that we had user-friendly, simplified classification that would be easy and importantly practical for clinicians to use. And that was based on evidence whereby treatment would have benefit. So in the 2024 guidelines, we simplified hypertension diagnosis into non-elevated blood pressure, which is a blood pressure less than 120 over 70. We would consider this as an optimal, ideal blood pressure. And this, of course, is in adults. We identified blood pressure between 120 to 139 or 70 to 89 as having elevated blood pressure. So if you're sitting in the audience and your blood pressure is 124 over 86, you've got elevated blood pressure. And hypertension, characteristically, is defined as a blood pressure of 140 over 90. And these are the three categories that we have used for the determinants of elevated blood pressure and hypertension. Now, it is really this group that becomes particularly important because it is this group that we need to start looking at who is at risk of cardiovascular events. And I'll come onto this in just a minute. So you may ask then, why are we targeting 120 over 70 as the ideal pressure that we would want all of our patients to have? Well, let's go back to some very early studies in 2002. This is a beautiful prospective study that looked at the association between blood pressure and various types of cardiovascular events, whether it was stroke, or ischemic heart disease, and even chronic kidney disease. And what you can see, as blood pressure systolic increases at all age groups from 40 to 89, there is a linear association with an increase in either ischemic heart disease mortality or ischemic heart disease events. And what I want to point out to you is that these events already begin at pressures as low as 120. So as clinicians, obviously, it is this that we're trying to prevent by ensuring that our patients do have pressures that are ideal, and that would be 120/70. This is another study more recently, again, to show that as blood pressure increases, there is an accumulated increase in disability-adjusted life based on cardiovascular disease events. But again, what I want to point out to you is that even at levels of 120 to 140, there is a huge risk of cardiovascular events. So really targeting this group of patients is absolutely critical. And in fact, it was the SPRINT study that you may be familiar with that really was paradigm shifting for us. This was a randomized trial of intensive versus standard blood pressure control. It was a beautiful study funded by the NIH that comprised about 9,000 patients. And these patients were either treated very intensively to a systolic blood pressure of 120 or just using their ordinary medication for normal control, for normal blood pressure control. These studies were done in family practices, in GP practices, and what the intensive, which was the experimental group, the goal was to get the blood pressure to 120 millimeters of mercury using standard care drugs. So no new drugs were introduced, no new other interventions were introduced other than the commitment to intensive control targeting 120. This was a 5-year study. The SPRINT study was a 5-year study. After 3.5 years, blood pressure in the control group was about 136 millimeters of mercury, and in the intensive group, blood pressure was about 121 millimeters of mercury. And just this lowering of blood pressure to 121 with standard clinical care showed us that there could be an almost 30% reduction in all-cause death. These data were truly paradigm shifting. And again, the only thing that was with the intervention was the ambition to lower blood pressure to 120. So it is for that reason that we and other guidelines are now targeting a blood pressure of 120/70. So when do you start treatment then? I mean, I've shared with you, of course, normal blood pressure, we won't treat those individuals. When do we start treatment for patients who've got elevated blood pressure and those who've got hypertension? Well, in those who've got elevated blood pressure, it really depends. And again, you may be sitting there saying, oh, my blood pressure is 126/83 or something. I've got elevated blood pressure. That's abnormal. Do I need to go on antihypertensive therapy? So it depends. What does it depend on? It depends on the associated cardiovascular risk. And in our guidelines, we've emphasized a lot the importance of evaluating the associated cardiovascular risk in the management of elevated blood pressure and hypertension. And again, I want to highlight to you, this is the group that we're talking about, the patients who've got elevated blood pressure. And we have defined elevated blood pressure in the office as 120 to 139/70 to 89. But we've also included the blood pressures for home blood pressure monitoring and for ambulatory blood pressure monitoring as well. So stratifying these patients based on their risk will help us in terms of how we manage these patients. We need to evaluate what are those risks that will predispose those patients who've got elevated blood pressure to having an event. These are some of the cardiovascular risk conditions that do have impact. If there's already established, obviously, clinical cardiovascular disease, if there's evidence of moderate to severe chronic kidney disease, other forms of hypertension-mediated organ damage, for example, left ventricular hypertrophy, vascular stiffening, diabetes mellitus, and hypercholesterolemia. These are cardiovascular risk conditions that need to be taken into consideration when you're evaluating when and how you will treat individuals with elevated blood pressure. In our 2024 guidelines, we've also included and highlighted the importance of some risk modifiers, those modifiers that will also impact the risk of accelerated or complicated hypertension and cardiovascular events. The 6 specific modifiers, of course, those related to hypertension, preeclampsia, etc., and also other modifiers which cross the boundaries, including ethnicity, including infection, socioeconomic deprivation, and others. So we have emphasized not only traditional cardiovascular risks associated with elevated blood pressure, but other modifiers that need to be taken into account when you're evaluating your patient who's got elevated blood pressure. I also want to highlight to you that it is important to evaluate the presence of hypertension-mediated organ damage, HMOD, and what we suggested in our 24 guidelines to evaluate the kidney, the heart, and the vasculature. We have suggested what needs to be measured and how. We've given parameters on how target organ damage should be evaluated. So these are some of the assays that need to be done, measuring kidney function, of course, through EGFR and ECG, echo when necessary, cardiac biomarkers as appropriate, and also where possible, evaluating the stiffness of the vasculature. This is not always available in all clinics and usually available in tertiary care academic facilities. But also, in terms of evaluating the risk of these patients, we highly encourage the use of risk scores. And for the European Society of Cardiology, we use the European risk scores, particularly the score 2. But in fact, you can use any risk score that is appropriate to your setting. And here in Canada, you could use those that are appropriate to Canada. So, when do we start treatment? Okay, sorry, this is not very clear, but we use a 4-step approach when we start bringing into our evaluation the assessment of cardiovascular disease risk. So step 1 is to assess for high-risk cardiovascular disease conditions. So our patient who's got elevated blood pressure, you start evaluating them for those risks that I have already mentioned. It's important to use the risk score, and as I said here, we use the score 2 to predict the 10-year risk of cardiovascular disease, to evaluate those modifiers, which may be sex-specific or not, and then also you may want to do some risk tests as well. So having evaluated all of that, what is the target that you should be striving for when you do treat your patients? And again, for the reasons I've just shared with you, for most of our patients, including those with diabetes, moderate to severe chronic kidney disease, previous stroke or TIA, and cardiac disease, we do suggest or recommend that the target is to 120 to 129 systolic. The other thing I want to say is that not all patients will actually tolerate a blood pressure that low. So we have also introduced the concept as low as reasonably achievable with the patient not being symptomatic. So let's just look at what this may be in real life. If we had a patient who came to the clinic, how would we go about using these guidelines? So let's consider this 56-year-old lady. She comes to the GP because she was worried about her blood pressure, which at the pharmacy was high. She doesn't have any past medical history, no family history of cardiovascular disease. She's had a fairly healthy lifestyle. She did have preeclampsia, but recovered well. At home, her blood pressure was 128/84. Her body mass index 26. Her office blood pressure 134/86. And so, of course, the question is, do you, as the clinician, have any concerns regarding her blood pressure? Probably in the past, we would have said, no, that's just fine. Carry on doing what you're doing. When you come back with your blood pressure 140/90, we'll start treating you. Let's go back to our parameters. She falls within the category of elevated blood pressure. Her home blood pressure was higher, was in the range of 120 to 134. Her office blood pressure fell within the range of elevated blood pressure. And when we look at her cardiovascular risk, looking at her bloods and the fact that she had previously preeclampsia, and also taking into account the score 2 risk assessment, actually we find that this patient has a risk of about 5% for a cardiovascular event. So when we go back to our algorithm in terms of how to manage this patient, we have gone through all the processes in evaluating her risks. Her 10-year predicted cardiovascular disease risk is less than 5%, and so she should be managed with lifestyle measures. So what are the lifestyle measures that have been proven to reduce blood pressure independently of pharmacological approaches? So how do we lower blood pressure using lifestyle measures? Well, this may be new to you. Increasing potassium intake. You wouldn't have read that in your textbooks years ago. Increasing physical activity, of course. Optimizing weight, managing your diet, reducing salt intake, reducing alcohol intake, and for good vascular health, no smoking. And this is obviously to ultimately reduce blood pressure and therefore reduce the risk of a cardiovascular event. Let me just share with you some of the new evidence related to potassium and to salt, because those are questions that always come up. The new evidence tells us that by reducing sodium intake and increasing potassium intake, there is a significant reduction in cardiovascular events associated with hypertension. This was a very large study, the SAS trial that was published in the New England Journal of Medicine a few years ago. And it was a study that looked at a salt substitute, a low sodium salt, which contained potassium, and the regular sodium chloride. And what we can see that the number of events was significantly reduced for stroke, major adverse cardiovascular events, death from any cause, and there were no real problems related to hyperkalemia. Of course, you've got to be very careful not to give high potassium in patients who've got kidney disease. So how do you go about increasing potassium intake? It's really a healthy diet. It's the DASH diet. It's probably the Mediterranean diet, fresh fruit and vegetables that we're all very familiar with. How do we reduce sodium intake? What is recommended is that sodium should be less than 2 grams per day or less than 5 grams, a teaspoon of salt a day. And the issue with sodium is that it's very difficult to control sodium or salt intake because it is the pre-prepared foods that are extremely high in sodium content. And so, making patients aware of checking the salt content of food is helpful. But it might be surprising for you to learn that the foods that have got amongst the highest sodium content are bread, cereal, and sauces. Very high in sodium. And if you start checking the labels, you'll be very surprised. So the diet that we recommend is the DASH diet. And this is really essentially a healthy diet of fresh fruits and vegetables, protein, adequate carbohydrate, the DASH diet. The dietary approaches to stop hypertension that has been shown to significantly reduce blood pressure without pharmacological intervention. Of course, physical activity is important, and these are some of the new recommendations. Aerobic exercise, at least 150 minutes a week, moderate intensity or 75 minutes per week for more vigorous activity. And also, it's now been shown that actually dynamic or isometric resistance training can also help blood pressure control. But not all patients are going to respond to lifestyle modifications. Let's go back to our patients who've got elevated blood pressure and who we have now identified as having a cardiovascular disease risk, and especially taking into consideration the 10-year risk. Well, it is these patients, if they have not responded to lifestyle measures and whose systolic blood pressure is greater than 130, that we now have to start using pharmacological intervention. And the intervention that we suggest is a monotherapy using one drug at low dose to reduce blood pressure. If blood pressure is still not controlled, we then go on to look at the algorithm that has been identified for pharmacological treatment of hypertension. And what we suggest, once your patient has got a blood pressure of either uncontrolled, non-elevated blood pressure or greater than 140/90, the suggestion is you start off with a low dose, double combination therapy, an ACE or ARB combined with calcium channel blocker or diuretic. If the blood pressure control is still not controlled, you can go on to low dose triple therapy, combination therapy. If blood pressure control is still not adequate, you increase, you up-titrate the triple combination therapy. And if blood pressure is still not controlled, we have to start thinking about secondary causes of hypertension, truly non-responders, and what we call resistant hypertension. And for all of these interventions, we hope that the intervention will have an effect within 3 months. I also want to emphasize again the concept, the ALARA principle. Although we target for 120/129, if it's not possible, if patients start having hypotensive type symptoms, then we treat to as low as reasonably achievable. Let's look now at another patient. A 64-year-old man comes to the clinic. He's been referred to the hypertension clinic. For the past 8 years, his blood pressure was well controlled using lifestyle measures and a combination of an ACE inhibitor and hydrochlorothiazide. Over the past 3 years, blood pressure control has been difficult. At home, his blood pressure is consistently above 140/90. He's gained some weight. He's not doing so much exercise. He's on an ACE inhibitor, calcium channel blocker, and a thiazide diuretic. In the office, his blood pressure is 162/88, and his mean 24-hour blood pressure is 158/90. He also has evidence on ECG of LVH. What do we need to take into consideration? He's overweight, he's got hypercholesterolemia, diabetes, sleep apnea. We need to exclude secondary causes, especially primary aldosteronism, which accounts for about 10 to 15% of patients who have secondary or resistant hypertension. And very importantly, we give him all these tablets, we need to ensure that he's actually compliant. So the question then is, how would we classify this patient in terms of his blood pressure? Well, by definition, he would have what we term treatment-resistant hypertension, remembering that we have identified that he is compliant, he's taking all of his medication. And this is defined as a blood pressure that remains above the goal despite the concurrent use of 3 different classes of antihypertensive agents, one of which is a diuretic, and all agents are used at optimal doses. That is the patient who has resistant hypertension, and the underlying pathology, the causes are really quite multifactorial. So how do we treat this patient? Sometimes these patients come, they've tried everything, and their blood pressures are just simply uncontrolled. So if indeed we have identified this patient as having true resistant hypertension, in other words, again, that we have confirmed that he is not responding to his treatment because he is compliant, the 4th line level of drug is spironolactone. And if you can't use spironolactone because of gynecomastia or other issues, you can also use eplerenone. Spironolactone is extremely effective. And in most cases, patients with treatment-resistant hypertension will respond. However, there are some patients who just still do not respond. You can add a beta blocker. And if still uncontrolled, you can intensify treatment. And now in Canada, it was approved last year that we can also do renal denervation. This is a device to denervate the kidneys and has been shown to be extremely effective in long-term blood pressure reduction. So renal denervation is now part of the guidelines for the treatment of hypertension. Our guidelines talk about very specific groups, young adults, pregnancy, and other important special considerations. I've mentioned to you resistant hypertension, but I also want to highlight to you older and frail patients, because this is a group that was by and large neglected previously. What we recommend in patients who are older, and we identified those as being less than 85 years and who are moderately, who don't have frailty and who are functional, we suggest and recommend, again, based on the evidence, that they should be treated as if they were younger. In other words, you follow the algorithm as for all adults with hypertension. However, in patients who are 85 and who are frail, and we have provided how to assess a frailty based on a scale, then you can use long-acting calcium channel blockers or inhibitors of the renin-angiotensin system and low-dose diuretics. It's really important to evaluate frailty. And the reason why we've taken this approach is that we know that even 85-year-old individuals who are by and large functional and not frail benefit from the protection of having lower blood pressure. At the end of the day, if you don't get the buy-in by the patient, and you don't get the buy-in even by the patient's family, all of these recommendations will not be effective. And so a large part of our guidelines has also been the recommendation for patient-centered care to ensure that when you're discussing treatment for hypertension, managing hypertension, lifestyle approaches, it's really important that this is multidisciplinary and that the patient is at the center of all of this. And we see again and again, because this is the silent killer, patients feel well, they usually are non-compliant and non-adherent. So a patient-centered approach is really important. So to summarize then, the new recommendations, we also suggest opportunistic blood pressure screening in young people whose parents are hypertensive, in patients with hypertension and no chronic kidney disease, high potassium intake or potassium substitution, low sodium intake. I didn't really mention, but restricting free sugar consumption, that really means the sodas. In adults with elevated blood pressure and low to medium cardiovascular disease risk, lifestyle measures is what is recommended. If after 3 months, lifestyle measures are not reducing blood pressure, then monotherapy is suggested. And in all hypertensive patients, irrespective of their cardiovascular disease risk, lifestyle measures are always suggested, and the introduction of pharmacological blood pressure lowering treatment. Our guidelines, in terms of the highlights, in terms of what's new, we've come up with new definitions, as I said, 3 user-friendly categories. We have emphasized the importance of out-of-office blood pressure measurements, evaluating risk. We've defined some of the lifestyle measures and pharmacological approaches, and importantly, as I said, in the new guidelines is the introduction of renal denervation. And as I said, in Canada, this was approved last year. And again, for those, while we may target 120 to 129, if this is not possible, then blood pressure as low as reasonably achievable. But at the end of the day, with all guidelines simply provide recommendations and never override clinical judgment. So please, clinical judgment at the end of the day is what counts. Now, I couldn't talk about the guidelines from the European Society of Cardiology, which is the latest of the international guidelines, without mentioning the 2025 Hypertension Canada guidelines. And this was published just last week in the Canadian Medical Association Journal. Now, these were very nice guidelines, actually, because these were guidelines that focused primarily on the primary care physician. So they were quite user-friendly. They used what they call the HEARTS framework, which is a model or a framework that was devised by the World Health Organization to take into consideration healthy lifestyle counseling, evidence-based treatment protocols, access to essential medicines and technology, risk-based cardiovascular disease management, a team-based care approach, and systems for monitoring. So the 2025 Hypertension Canada guidelines used this approach for their recommendations. And actually, if we look at what they have suggested, they have also focused on a blood pressure of 130/80. If the patient does not have blood pressure 130/80, in other words, less, they said that these patients don't have hypertension. We would categorize them as being having elevated blood pressure. And again, going on to out-of-office blood pressure assessment, and if greater than 130/80, diagnose as having hypertension. And the algorithm for treatment, of course, starting with healthy lifestyle, as I've just mentioned to you, they have gone on similar to what we have suggested, using combination therapy, low doses, and up titrating as necessary, with stage 4 being the addition of spironolactone, especially in patients with resistant hypertension. What I think is quite nice about the Canadian Hypertension Guidelines is that they've recommended the table for single pill combinations, and they've based this on accessibility and also the cost for tablets. And I know that one of the more frequently used combinations is telmisartan and hydrochlorothiazide. Okay, so let's get back to what I started with, the hypertension paradox. Here we are in 2025, and we haven't done much better than what Avram Chobanian brought to our attention in 2009 in terms of uncontrolled hypertension. In fact, things have got a little bit worse despite all of our efforts. Why is this? Hypertension is a complex disease. It is multifactorial. We know that there are complex environmental factors that contribute to it. We know that the comorbidities, for example, obesity and other chronic conditions, can complicate the management of hypertension. Adherence and compliance in a chronic disease is always a challenge. Actually, the causal mechanisms, the fundamental mechanisms, remain unclear. And perhaps we need to ask ourselves, perhaps despite all these therapies, maybe we still don't have the best therapies. Maybe our therapies are not that perfect, especially when we have so many patients who appear to be non-responders. Well, this has been an incredibly exciting past few years for clinical hypertension, because for the first time in about 15 years, there have been a number of new, interesting therapies that are being considered for treating hypertension. The next frontiers in antihypertensive therapies, there are a few new classes that I want to highlight to you, because it's important as clinicians that you're aware of where we're heading in terms of new therapeutics. You'll be surprised to hear that we are now considering RNA therapeutics. We have an siRNA and an oligosense nucleotide that target angiotensinogen in the liver, downregulate the gene of angiotensinogen, and thereby reduce the production of angiotensin II. One injection of zilebesiran every 6 months reduces blood pressure significantly. And the phase 3 clinical trial will be coming out very soon. This is paradigm shifting. The second group of RNA therapeutics is the Ionis preparation. This is an oligosense nucleotide. One injection every month or every 2 months reduces blood pressure. You don't have the issues of compliance, of adherence, and your patients are protected from elevated blood pressure. Non-steroidal mineralocorticoid receptor antagonists to overcome the effect of, spironolactone, gynecomastia, etc. Very importantly, and I'm sure very soon we're going to see new FDA-approved drugs that actually inhibit the production of aldosterone by inhibiting aldosterone synthase. So in the past, we used MRA, which blocked the effect of aldosterone by preventing aldosterone from binding to its mineralocorticoid receptor. Now we're actually inhibiting the production of aldosterone. And the drugs that are now being used in clinical trials, lorundrostat, baxdrostat, dexfatrostat, and another compound that is still in research. A very exciting area of new classes of drugs. And then there is the other group targeting the endothelin system. In 2024, the ETA receptor, ETB receptor antagonist, the dual endothelin receptor antagonist, aprocitentan, which inhibits the effect of endothelin, was approved for the treatment of resistant hypertension. So with that, I'll stop, and I'll just say that if you really are interested and you want more information, the guidelines are available in the European Heart Journal and also in an app.
Great big thank you, Dr. Touyz, for this absolutely fantastic lecture. Congratulations on these transformative guidelines. It's very exciting to see the advancement in this field that many of us think we know about hypertension, but there's obviously much more to it than we think we know. We have a few questions. Are there questions in the room before I go to the chat online? Yes, go ahead, Simon.
Thanks, Rhian. That was superb talk. So I have two very kind of specific questions. One is in the elderly patient where it seems pretty clear they have like very stiff arteries. How do we get an accurate measurement of blood pressure in that patient?
Yeah, with difficulty. Arterial stiffness is obviously a problem with aging. And we still use the classical, we still recommend the classical sphygmomanometer-based approaches. Sometimes 24-hour monitoring can give you some indications. The issue there is very often in these patients, they have non-dipping hypertension, which is actually an indicator of increased risk. But other than the standard approaches, we don't recommend anything specific. I don't know, Stella, from your point, if you have anything to contribute.
So, Stella? We're talking about elderly people with arterial stiffness.
The one thing that we do is we can evaluate directly vascular stiffness, and that's just another indicator of target organ damage. And there are a number of approaches that we can use, pulse wave velocity, etc., to actually directly measure vascular stiffness. But that's not going to tell you about the blood pressure per se.
Yeah, that's exactly very right. So we have now new technology, so we can measure arterial stiffness, but also central blood pressure. Unfortunately, we don't have cutoff points for central blood pressure, but this is really what we should be measuring in older people, because we see that in younger people shouldn't. Your show.
No, not at all.
But in younger people, there is a pulse pressure amplification. So there's difference between central and peripheral, but we lose that as the arteries stiffen and the peripheral arteries as well. So that's why the central blood pressure is really what is important. But with time, hopefully, will be.
Yeah, the problem is these approaches are not available widely. They're usually, if they are available, they're available in academic institutions or centers of excellence. And we are working towards becoming a hypertension center of excellence. So hopefully with time, we'll be able to provide that. We've got all the equipment, the technology to do it. So hopefully with time, we'll be able to do that as well.
Thank you. And thank you, Stella, for adding to that question. Yes, one more question in the room, and then we'll go to the chat. Yes.
You said we should be eating less than 2 grams of salt a day. We're actually eating more than 9 grams.
Yes.
As you said, most of it is coming from processed food. Why can't we or our government put pressure on an industry which is adding salt to increase shelf life?
Yeah. So this, if you really want to get me going, when I was working with Norm Campbell, he was a very, very strong advocate, and we had a SALT working group to try and advocate to the government, to the food industry, to reduce the amount of sodium in our food in Canada. This goes back now 20 years. We started to work on this. I can tell you it was impossible to work with the food industry. And unless this would have been mandated by the government, it was just impossible to change anything. But what I can tell you is that we know it's effective. For example, there are 2 countries that have had a huge impact in reducing their sodium content in the foods. One is actually in South Africa, where it was government mandated, and the other one was in Portugal, where the bakers were mandated to reduce the amount of sodium, of salt in the bread. And the effect was very clear in terms of the reduction in blood pressure at a community level. So it can work. Here in Canada and the US, it's very difficult to work with the salt, the food industry. Something else, our salt content in cereals is actually higher, the same cereal, than in the US. Very interestingly. So if you eat Frosties here, the salt content is higher than in the US.
But don't eat Frosties. Okay, we have lots of questions, Dr. Touyz, in the chat. So we're going to go through this quickly. I see, Ariane, your hand is up. I'm going to get through a few questions. Is renal denervation available at the MUHC? Just quick answer.
Currently, no, but we're working on it.
Okay. Is high potassium itself beneficial, or is it the healthy diet with potassium supplements have the same effect?
A healthy diet is what we recommend. And in patients who've got hypertension or elevated blood pressure, we recommend a healthy diet with a high potassium content. We're not saying potassium supplementation. It's a high potassium healthy diet that is recommended.
Okay, Sasha Bernatsky wants to know, how much does diastolic blood pressure matter? And I was thinking about that. We used to use the number 85 as a cutoff when I was in medical school. How important is this diastolic versus if the systolic is normal?
Yeah, it is as important. You'll remember in those the cardiovascular event slide that I showed you, cardiovascular disease and events start happening not only with a blood pressure greater than 120, but a blood pressure greater than 70 as well. So diastolic blood pressure is also important to consider.
Okay, Ariane, you want to unmute yourself? Dr. Morelli, go ahead.
Thank you very much, Rhian. That was superb. I want to just ask you to take us a little bit to where you see the gaps in research. We haven't seen that much funding go out for hypertension research. There's a lot of good level 1 evidence in the guidelines. Is it in the implementation science? You've talked about drug discovery and obviously precision medicine, but where do you think the research gaps are that would help us capitalize on all this amazing data that's been around now for 25 years? And why aren't we seeing more money out there? Is it because the drug industry is taking it over? Speak to me as a funder.
Okay.
Tell me what you think.
Yeah, I can. You're right, Ariane. For a long time, the pharma industry, they were effective, they said, antihypertensive drugs. And then these drugs became generics, and it wasn't worth the industry to start investing in looking at new drugs until some of the mechanistic science came out, upon which some of these new approaches have now evolved. The biggest gaps we have from a clinical point of view and an impactful point of view is indeed implementation. We know we can have all these guidelines and everything else, but unless they're properly implemented, that is a challenge. But probably a bigger challenge, and especially for those of us who treat hypertension, and especially complex hypertension, is that we use these same protocols to treat everybody. And I can tell you the majority of the patients, especially the complex hypertension, they are non-responders, which means we still need to do a lot of the mechanistic work to better understand mechanisms of the disease and, importantly, new targets. Because without that, we will continue to use all these drugs, spend all this money, and patients will remain non-responders. Of course, the other big gap that we can't not think about are the effects of comorbidities, obesity in particular. This is making hypertension even more complicated for us because not only are these patients non-responders, but they have the comorbid risk of the events that we're obviously trying to prevent. I can't stress enough, hypertension is boring for clinicians, but it's probably the most important clinical condition that could truly have impact from a global population, community, even individual point of view in terms of a better, a more healthy community.
Fantastic. David Rosenblatt has a long question, but it seems to be related to the population and how we're going to, optimize this. What would you recommend for healthcare, to manage? Like who should be taking care? Who should be managing hypertension?
Yeah, so I think because it's so common, it's a multi-team approach. There's definitely a place for, non-healthcare providers to help in the screening and the education of hypertension. One of the most effective blood pressure hypertension prevention programs was the BARBA program in the US, where Ron Victor said, where are our worst communities in terms of risk of hypertension and cardiovascular events? And he identified it in the African American communities. And these patients have very severe hypertension. They do not get access to treatment. And he said, where do these individuals go most, especially the men? They go to the barber shop. So what they did is they trained the barbers to screen for hypertension, to treat initially for hypertension, to educate the patients. And this program, an NIH-funded program, has been unbelievably successful. So yes, in the community, there's place to do a better job. Our healthcare providers in terms of primary care, for sure, the healthcare team plays a critical role. Education. And our children from a young age, it's too late to educate our patients who've already got stiff vessels, chronic kidney disease, and LVH. It's too late. They've got irreversible fibrosis and inflammation and everything else. So, starting there. So it's really multidisciplinary.
Okay, so it is 1 o'clock, so I will have to close the official portion of the rounds, but there are many questions left in the chat. So Sylvia, I'll ask you to please leave the link open, and maybe Dr. Touyz, you can, there's a lot of questions. Maybe you can tackle some of these questions individually if you don't mind. Could you stay a few extra minutes?
I can stay for 5 minutes.
So 5 minutes. So Dr. Touyz is going to we'll keep the link open, but it is 1 o'clock, and I know many of you have to go back to clinic and to your research. So thank you. First of all, thanks for making you use the word boring. I won't use the word boring, but thanks for making hypertension exciting again. So thanks for this fantastic, comprehensive lecture, and congratulations on your terrific work, you and your team, on providing these transformative guidelines. So I wish everyone a great afternoon. Thanks.